Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. The guidelines for restless leg syndrome were updated earlier this year. One thing you may have noticed is the minimal guidance around PLMD. This had to do with the way the guidelines were structured and the weight of evidence available. Our guests today have published work assessing for the persistence of PLMs once the sleep apnea has been treated. Dr. Gulcin Benbir is a professor of neurology and sleep researcher based in Turkey. Dr. Lourdes Del Rosso is a sleep physician and professor at UCSF and was on the task force for the updated AASM guidelines for the treatment of RLS. Welcome. Thank you both for being here today.
Thank you for inviting us.
Thank you.
So, Gulcin, tell me about your paper.
Thank you again for this kind invitation. As you have mentioned, periodic leg movements in sleep is usually underlooked in sleep laboratories and also in patients with obstructive sleep apnea, which is the most common sleep-related breathing disorder. And the diagnosis, treatment of this common disorder, obstructive sleep apnea, is very important, as we all know that it is associated with hypoxia, cardiac arrhythmias, increased blood pressure, and secondary consequences. So, in patients with OSA, if periodic leg movements are associated, then we wonder if these patients have a worse sleep quality and whether this comorbidity affects the compliance to PAP therapy, which is very important to reverse these unwanted consequences. So in this paper, we investigated these OSA patients with or without coexisting PLMS, and we found out that the combination of sleep apnea and periodic leg movements actually has a negative synergistic impact on both sleep architecture and also significantly reducing total sleep time, significantly reducing deep sleep stages, and this is actually very important, highlighting the compounded burden of coexisting sleep disorders. So we believe that our findings underscore the importance of identifying, assessing, and addressing periodic leg movements in patients with sleep apnea to optimize sleep quality of these patients and also to mitigate associated health risks.
So, Lourdes, when does PLMS become PLMD?
That is the million-dollar question, Seema. Our ICSD revised text revision, the third edition, states that you need to rule out other disorders for PLMs to actually be diagnosed as periodic leg movement disorder. In children with a PLM index more than 5, in adults with a PLM index more than 15. However, the caveat is in the fact that a high percentage of adult patients with PLMs will have restless leg syndrome. So in these patients, the PLMs are a motor manifestation of restless leg syndrome. We therefore cannot call PLMD in a patient with RLS. That goes both for children, which is even more complicated, Seema, because in young children, we also have demonstrated that the leg movements are not that periodic, that they are more isolated, while in adolescents, they start becoming periodic, and this may have to do with myelination. So it is difficult. It is very difficult because a lot of times we have patients without restless legs syndrome, and we see PLMs in the sleep study, but then maybe they had symptoms when they were younger, or maybe they will develop. So there's a lot still to study in this field to really understand if all PLMs are related to RLS or if there is a subset that are independent.
So I heard you say that the PLMs are the motor phenomenon. And so then are we saying that the RLS is a sensory part? So are they intertwined, or is this two different things?
No, that's a great question. We have task forces right now from the International Restless Legs Study Group trying to identify and phenotypes of restless legs. So I won't say much, but we are looking into adults separate than children. And Dr. Benbir and I are in the task force as well. So I would say there is both, but we still need to identify if there are two distinct phenotypes or not, if there are different manifestations at different ages or in different populations.
So, Gulcin, in your paper, I was kind of surprised, or maybe not surprised, but I saw that hypoxia was associated with higher amounts of PLMD. And so in my brain, I feel like that should get better with PAP therapy. Did it?
Hypoxia may also be worsened by PLMS, but it is also associated with that finding where PLMS is actually more commonly seen in patients with more severe sleep apnea. So these hypoxia level may also be related with the severity of OSA in these patients who have more common PLMS or PLMD as well. As you mentioned, these hypoxia did not improve in a considerable number of the patients. So this is because actually the underlying pathophysiology is quite different, and this is why actually periodic leg movements should be assessed other than breathing parameters in these patients.
Well, and that's an important point, right? Because in the US, we have shifted a lot to home sleep apnea testing, but I understand in Turkey that you still do primarily polysomnography.
Yes, this is true. Home testing is also available, especially in some private centers. In many little public centers, it is also available that we can do these home testing. But in most of the other centers, sleep laboratories, we usually do these PSG testing in sleep laboratories.
So when I was a fellow, I remember being taught that PLMD or PLMs get better with PAP therapy. But then in your paper, you showed that you reversed, you fixed the AHI and you reversed the hypoxia, but you still had persistent PLMs in 30% of patients. So has our thinking shifted?
It was actually higher.
Was it higher?
Yeah. So 36% resolved. But
Oh,
47 have persistent and 16% actually worsen after. So we have seen this and people
okay.
have been studied this. Some people say that once the obstructive apnea is treated, you can see the actual PLMs emerging. But in this case, what it was amazing is what, as you said, the the time spent with saturation below 88% was associated with the residual PLMs, but the time spent below 88% in the diagnostic part. So even if it resolved in the treatment part, it was the untreated part that was correlated with the PLMs. So this brings up to hypoxemia as another contributor. And this was one of the very early, very, very early theories of RLS and PLMs, that when it was started historically to be treated with vasodilators and everything. So I think that we're looking into something. And we know that iron, of course, improves the oxygen carrying capacity. So we can be looking at some mechanistic approach that we can use for treating PLMs in a particular group of patients.
Oh, that's a really good point. The group of patients who didn't get better with treating their sleep apnea, I was wondering if that cohort of patients was sicker or older, because don't we see more PLMs in that group too?
It was a cohort without selection. So it was just a continuous cohort of patients that were seen even in our sleep center. So it wasn't, you're right, because the patients that are going to be done in the lab are not your regular patients that are doing the home studies, right? So you're right to think like that. So I think that there is a potential that the patients may be worsen, and because obviously they qualify for an in-lab study. The one thing, Seema, that it limits a lot of the research, at least in the United States, is that very few funding for research like this. So, Gulch and I, we do it because we love it, and we spend a lot of time scoring, and, we score our own studies, and we have a couple of residents or fellows that work with us, but it is really a labor of love because there's pretty much no NIH funding for PLMs, and there's very, very little funding for it. So this is, the idea to have just regular people, younger people, healthier people, and see how many of those have truly incidental PLMs, because we can't call them incidental when we're actually doing the study because the patient has a symptom, right?
Good point.
Yeah.
There are other things that can cause PLM. So what other neurological things can cause PLMs?
Well, actually, it is also important to, of course, investigate if there are some other secondary causes which can cause PLMS. And the major neurological processes that affect or that can cause PLMS are the ones which actually involves the spinal cord, such as radiculopathies or peripheral nerve diseases, but also some other diseases, brain diseases like stroke affecting the central areas are also reported to cause PLMS, especially if this stroke area is related to basal ganglia. But actually, if you ask me what is the most common neurological disease causing RLS and or PLMS, it is actually MS. MS, multiple sclerosis, affects both central and peripheral nervous system, and by this way, actually, PLMS is the most common associated sleep-related disorder in these patients with multiple sclerosis. So it is also very commonly seen, and it also augments the symptomatology of the underlying disease as well. Plus, it also complicates the course of the PLMS or RLS, so making our treatment is little intriguing and difficult as well.
Lourdes, you did a paper before on RLS and sleep apnea. Is this similar to that?
Yeah, so we've been looking at the combined, and thank you for asking this question because we are really excited. So we're looking at the combined. How does how there is COMISA, right? The co-insomnia with obstructive sleep apnea. We called it COROSA.
Oh, geez.
We call it co-RLS and obstructive sleep apnea. We found that these patients, this is outside of these two papers that we're discussing, but we found that patients with comorbid RLS and obstructive apnea had higher depression, anxiety than patients with either alone. And we are continuing working into this area, interestingly, and we are now working on a review of what is the literature on both. So this is an emerging area of what is the combined effect. We had a couple of papers on the combined effect of PLMs, and we're looking now into the combined effect of RLS and OSA.
Okay, but I have to ask you, right? More comorbid anxiety and depression. Is the RLS from the meds for the anxiety and depression?
That's a great question. So we would have to look into correcting for the presence of that, because that is exactly a really, really good question. It wasn't in our first study, and that was a small group of patients that we did questionnaires for the GAD-7 for anxiety and for depression, and it was at the time of diagnosis of RLS, so without treatment. And I would have to review that paper. We weren't presenting that one, but I would have to review it if they were on medication.
So let's take a short break, and when we come back, we'll talk more about the importance of periodic limb movements of sleep. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Prepare for the future of sleep medicine at Sleep Medicine Disruptors 2025, November 14th through 15th. This hybrid course will provide a unique and virtual learning experience exploring the disruptive innovations altering the healthcare and sleep medicine landscape. Registrants can attend either virtually or in person at the Austin Marriott Downtown in Austin, Texas. Register today at aasm.org/events.
Welcome back to Talking Sleep. We're talking with Dr. Benbir and Dr. Del Rosso about their work on PLMD and obstructive sleep apnea. Gulcin, how do you look at PLMs? Are these innocent bystanders, or is this a pathological process?
I think they are not innocent. Actually, the finding of our study is also a part of this question, actually, the answer of this question. I believe that PLMS, PLMD, like RLS, is a sleep-related movement disorder because it causes subjective symptomatology like leg pains in the middle of the night, sleep fragmentation. Plus, it is also important to say that they are associated with increased cardiovascular risk because these leg movements are associated with arousal and sympathetic activation. So this sympathetic activation increases the risk of secondary complications like heart diseases and stroke. So this is why I believe that they are not innocent, but a pathological process, a part of biological process. Plus, I can also say that there are some other studies in which the coexistence of PLMS has been shown to worsen the prognosis of these important cardiovascular diseases like stroke. This is why I believe that they are a part of pathological process.
So I'm glad you brought up that cardiovascular risk because that was a kind of a big talking point a few years ago that we saw that is this sort of a marker of underlying cardiovascular disease, or does it lead to because of the autonomic sort of the autonomic reaction almost, or what happens when you have PLMs and the arousal. So is it causing or is it a marker of underlying elevated cardiovascular risk?
I think there is bi-directional relation in between, but still, if these PLMS is associated with arousal, the risk increases. There is a study in which these periodic leg movements are divided into two as spontaneous leg movements, which are not associated with any arousal, and those which are associated with arousals. So at the end, the authors have said that, or observed and demonstrated that these leg movements associated with arousals are actually linked to these cardiovascular risks, but the others are not. So in this term, I believe that there is a bidirectional relationship between these two. But as you mentioned, the presence of an underlying disease associated with increased sympathetic activation will also enhance the occurrence of PLMS as well, because the prevalence studies have demonstrated that PLMS, RLS are more common in these patients as well. So I believe that there is a bidirectional relationship.
So do symptoms correlate with the number of PLMs? You know how sometimes you'll read a study and somebody has like 800 PLMs, but they may not have either restless legs or leg cramps or leg movements or anything that you can really tie to it. And other people will have a handful, but they'll have significant RLS or leg cramps or something like that. And so is there a correlation with the number of PLMs? Like, should we look deeper if we see a lot of PLMs to find symptoms? Or is this just unrelated?
I think we need more data about that. I have a theory about the arousals and the PLMs. You know, I'm not sure somebody may have already worked into this. If I read it and I'm repeating somebody that wrote it, forgive me, but I think that is a theory that I developed. I may have read it. But I do have a theory that the longer that you have PLMs, it is possible that the more neuroplasticity that occurs in your brain and it corrects so your arousal threshold increases. Because what I've seen is that PLMs tend to be, or leg movements tend to be very disruptive in children. And then as you get older, you see older people and they just kick a lot through the night and they keep sleeping. So I think that just like with obstructive apnea, when somebody has obstructive apnea for a long time, the arousal threshold changes and gets higher and it doesn't wake them up that much anymore. I think it's the same thing with PLMs. So it may be that, you know, they're not really, the arousal threshold has changed, but yet the consequences and the effects may continue. So I think that this is why Gulcin and I love this area, because there's so much, there is so much to learn and know. I do believe that I do not ignore them. That's my practice. I don't think Gulcin does either. We'll ask her, but I think that I always include them in all my reports, and I want to be sure that the patient is if there is elevated PLMs, I try to address them. I check iron. I know we'll talk about iron before I consider the residual sleepiness related only to obstructive apnea. Do you do the same, Gulcin?
Yeah, we do the same, dear Lourdes.
Okay, but if you're saying that their arousal threshold has changed and it's not waking them up as much, then why would we think it's making them sleepy?
Not everybody has these issues. I think it depends on how long it's happened, what other contributors there are. And also we know that they are associated with sympathetic activation. So they may have other markers. So we are looking only at one parameter of sleep, which is the arousal index, but there may be contributing to inflammatory markers or sympathetic activation or other situations that may be contributing to the daytime symptoms.
Because that's what I'm wondering. Now after visiting with you in my brain, I'm thinking, well, this probably changes my assessment of residual hypersomnolence in those who have, well-treated sleep apnea on CPAP. And so then should we go back and look at their PSG and look for PLMs and potentially treat that before we start a wake-promoting agent?
I am an advocate that, especially now in the day and age of home apnea testing, if you have someone with a home apnea testing, you diagnose with obstructive apnea, they're adequately treated with CPAP, they're still sleepy. I am a strong advocate of having a in-lab sleep study. There are many things that we can learn from the in-lab sleep study, not just the periodic leg movements, but we can see different arousal, cyclic alternating patterns, other parameters that can give us insight into the sleep quality of the patient and what's going on.
So, and then here's the other part I get stuck on, is that when I was a fellow, we were taught, there's FDA-approved treatment for RLS, but not FDA-approved treatment for PLMD. So is that still true? And then B, how would we treat this? So let's say I have somebody whose sleep apnea appears to be well treated. The AHI is normalized. They're not hypoxic, but they're still sleepy and they have PLMs. How do I treat that?
My to-go is I check iron levels. I screen for RLS and I check iron levels. That's my first to-go.
Okay.
What about you, Gulcin?
Yes. As the Lourdes mentioned, we also test iron status of the patients in these patients with OSA treated with PAP, but still having residual sleepiness as well. So in this case, of course, if there is an iron deficiency, we should replace it, and we are doing it in our clinical practice. Plus, we should also search for the exacerbating factors like alcohol or caffeine intake close to bedtime, or use of other drugs which may exacerbate these movements, such as antihistaminergic or serotonergic drugs. So these are the number one treatment in these patients with PLMS.
So I didn't hear you say any treatment other than iron that would overlap with RLS then. Is that correct?
Well, actually, yes, this is the number one treatment that we should do, which is iron supplementation plus avoiding the other factors which may exacerbate the condition. But then, of course, if these first steps do not solve our problem, if there is still, there is a clinical symptomatology of hypersomnolence and the PLMS is continuing also in our PSG recordings or in clinical questionnaires, then we of course continue with some medications. As you have mentioned, there is no clear data about the treatment of PLMS or PLMD in contrast to RLS, but because these two disorders share the same mechanisms, underlying pathophysiological mechanisms, similar treatment options are used for PLMS or PLMD as we do it for RLS.
And just to be clear, you're not saying treat the PLMD unless you think it might be causing symptoms, right? You're saying that this is something we should consider in the differential diagnosis of continued hypersomnolence in sleep apnea that's treated.
Yes, of course. I mean, we made our differential diagnosis and every other secondary causes have been excluded. And then, of course, we go with these treatments. In Turkey, this is how we do it in practical issues.
So, Lourdes, do stimulants make PLMD worse? Or PLMs worse?
Most of the diagnoses that we in sleep medicine use stimulants for already have a high risk of PLMs. So we have patients with narcolepsy have high risk of PLMs. Patients with ADHD have high risk of PLMs. So it is really hard to tease out, especially because there is a high night-to-night variability. It's hard to just address it. I think Gulcin is right in that we need to focus. Right now, the best tool that we have is to address the iron deficiency, as the guidelines state. Also, because there's a high amount of non-anemic iron deficiency that is missed. We are used to looking at iron in terms of iron deficiency anemia, and when patients are not anemic, we're comfortable. But I think that it is important for us to understand that there is other iron deficiency conditions that are not necessarily anemic. And one of those is brain iron deficiency that contributes to RLS. So for us, ferritin levels that are less than 30 are definitely qualifiers for non-anemic iron deficiency, and less than 50 to supplement for RLS, and PLMs that are not associated or undiagnosed.
2025 marks the 50th anniversary of the AASM. Here is Carol Westbrook telling us about the early days of the AASM.
After we achieved our initial goal of having some members and therefore some funds, it became obvious to me and to Philip that the way the organization currently was set up was not financially solvent. It needed to, because there were many offices, the office of the president and the office of the treasurer and so on, and our office, which was free. But it became clear that we needed to centralize. That concept was taken to Bill DeMint, who agreed, asked me to be the director of it, and I agreed. And so now we had membership. Now we had to look at making it financially stable.
Now back to our conversation. So I'm really glad you brought up iron, and I'm really glad you brought up treating iron deficiency without anemia, because I feel like this is where sometimes we sort of clash with our primary care colleagues. And so what I'm wondering, two things. I'm wondering if you have a theory about leg cramps and iron and PLMs. And then I'm also, I want to pick your brain about how to look for iron deficiency and then how to treat it. So tell me about the leg cramps.
Yes, well, leg cramps are also classified under the disease disorders, which are named as the sleep-related movement disorders. So you don't have to be sleeping, but those leg cramps, which occur in the bed during the night, are diagnosed as these leg cramp movement disorder. But here, of course, the pathophysiology is a little different than that we see in RLS and PLMS. Here, the lack of movement during the night and the changes in some minerals such as magnesium become more important in compared to those we observe in RLS and also in PLMS. I think the pathophysiology is a little different. This is what I believe, but I wonder what Lourdes is going to say.
Yes, leg cramps is one of those things in which I think as sleep physicians, I feel a lot of times with my hands tied. Don't you see?
Yes, I do.
Yeah, it is one of those things that we need to study more. I wonder, like what you're saying, if patients who are, when you're kicking 100 times per hour, aren't you prone to cramp your leg? That is one of the one of the thoughts that I have. And other things is one of the things that I have noticed is some people with a lot of stress and tension, they have a lot of tightness. In those patients, you know how we recommend nighttime massage before going to bed? In those patients, that's what I recommend, but we definitely need more research on leg cramps.
So let's talk about iron. What tests do you order? Is this ferritin? Is this iron panel? How do you approach this? Lourdes?
I order a full iron panel and ferritin levels CBC as well, because if I am going to opt for IV iron, the infusion center is going to ask me for a CBC. And more often than not, now that I am treating a lot of adults with RLS, I order CRP.
Really? Why do you order CRP?
Just to be sure that the ferritin is not falsely elevated since it's an acute phase reactant.
Oh, that's a really good point. And then what directions do you give your patients before they have their blood drawn?
Right now, we've been having a conversation with some other colleagues here. I think globally, actually, some colleagues globally about what to do and how many days to wait. So I think the consensus is going to be 2 days without iron supplementation, so 48 hours without taking any iron supplementation, and doing the blood test fasting.
And no red meat?
Yes.
Okay. So help me understand this. So let's say you do your panel and your serum iron is normal, but your ferritin is low normal, like 20, and you have RLS. What do you do?
We guide the ferritin levels because iron level is very much responding to intake. It's very quick to respond to intake. So between the ferritin levels and the percent transferring, we be sure that it's safe. It's not in the high risk, like percent transferring to be 45 or 50 or be really high. In those cases, I'm more cautious. But if ferritin levels are really are low, like what you're mentioning, I use the other levels just to be sure that they are stable, that they're not extremely high, and I proceed with infusion.
Oh, so
I
even if it's normal.
I don't use the iron level to guide my decision to do the infusion. I use ferritin.
Gulcin, is that your approach as well?
Yes, we also look for the ferritin.
And so teach me how you do IV iron. I mean, I know there are different formulations, and I know there's only one that was identified in the RLS guidelines. Tell me about that, and tell me why iron formulation matters, or even if it does.
Well, ferric carboxymaltose has been the most studied, and that's why I made it to the guidelines.
Okay.
But other formulations work. Also, I think low molecular weight iron dextran is in the guidelines. It doesn't have the strength of the evidence because there's less studies.
Yeah.
But iron sucrose made it to the guidelines for patients with chronic kidney disease, for example, patients on dialysis, patients with kidney disease, but did not have the same evidence for patients without kidney disease. So IV iron sucrose is not recommended for patients with normal kidney function. Now, the other preparations, ferrumoxytol, for example, it's also available, but it doesn't have enough evidence. But it crosses the blood-brain barrier, like low molecular weight iron, ferric carboxymaltose, ferrumoxytol, they all cross the blood-brain barrier, and they are potentially effective for patients with restless leg syndrome. There is a concern with hypophosphatemia with ferric carboxymaltose. So there's significant concern because the hypophosphatemia can drop low. And for some patients, this may be important. It is transient and it occurs during the first days. For us, for example, when we did our research in children, we check phosphorus levels at 2 weeks. And we did not find any single case of hypophosphatemia. But studies that have done with checking levels sooner, like within the first week, they have found that. And the implications are unknown in this case. So I would consider low molecular weight iron to treat RLS. I will not consider iron sucrose. It is not proven unless in kidney patients.
Oh, that's interesting. So then it does matter, because where I'm thinking of is if you are, like, I'm an independent, I'm not associated with a hospital. And so if I partner with an infusion center, I feel like I have to use what they use.
I actually advocate for the patient. So I have orders for all the types of preparation, and I advocate for the patient. Sometimes I have had denials, and now we have the guidelines.
Yeah.
In the past, I had my papers, which was very much conflict of interest. They will look at the papers and say, but this is you. But now we have the guidelines, and that is really great because we can support another preparation, especially not iron sucrose in this case. Yes.
Yeah. And the reason I say that is I had somebody that received IV iron, an IV iron transfusion, but it wasn't it wasn't the one in the guidelines, and she got really, really worried about it. And so then we had to have a conversation about, sort of the nuance about it. And I feel like insurance is, sometimes a barrier, sometimes it's infusion center, I don't know. But I was curious about how much it mattered. So then what's our target ferritin for RLS, and is it the same for PLMs?
Yeah, I think there is no guideline for PLMS, but yes, we follow the same target ferritin as we do for the RLS. For the adults, the ferritin level should be 75 milligrams or above, but for children, 50 milligram or above is acceptable for the ferritin levels. But here we should also check for the transferrin saturation, because before giving iron supplementation, if this transferrin saturation is high, which means above 45%, then it means that the blood is saturated with iron. So in this case, even if ferritin levels are lower than these thresholds, giving extra iron will cause unbound iron in the blood, which will be intoxicating. So transferrin saturation is an important biomarker for ferritin or iron supplementation when there is a ferritin deficiency or decreased ferritin. Yeah.
Gulcin, that's a really good point. I'm glad you brought that up. That's a really important point. So do you have a call to action for us, or maybe a take-home message?
Yes, thank you for this opportunity, first of all. As we have discussed during this lovely hour, PLMS is an important sleep-related condition that sleep physicians should be aware of and assess in these patients with OSA or in other patients as well. We know that PLMS commonly associate RLS. This is actually quite well known, but when it associates sleep apnea, obstructive sleep apnea, it is usually underlooked, but it shouldn't be, because we know that it worsens the clinical symptomatology and it also affects the beneficial effects of the PAP therapy. This is why it is important to search for the periodic leg movements, especially in patients with sleep apnea, especially if there is a complaint of excessive daytime sleepiness even after effective PAP treatment. And assessing iron status is also very important in these patients.
Lourdes, how about you?
Think about the legs, please. That's my call to action.
Wonderful.
Yes, please. I think my call to action is ask patients these questions. Think that there can be comorbid conditions. We and some of us are so used to treating patients with OSA, and sometimes we treat them for a long time, and we're very well intentioned. We see them yearly, we treat them yearly. Remember that symptoms can worsen in the elderly. So our patients, even though we have been following them for their OSA for 10 years, symptoms may develop and things may change. Medications can be added. So think about it, keep it in your radar, and I think we can help our patients sleep better. What I wanted to say, particularly from Dr. Benbir's work, is that she, as a neurologist, is looking into the more detailed movements into various disorders, not just restless legs and PLMs, but looking into narcolepsy, into multiple sclerosis, like she mentioned, patients with stroke. So I think her, in her position of neurologist, is really digging into these movement disorders in neurological conditions. And I, in my position of internal general medicine, I'm looking at it from the perspective of the comorbid depression, anxiety, effect of medication. So I think this is phenomenal because it looks at the integration of the multi-specialty aspects of sleep medicine.
Which is what we love about our field, isn't
Exactly.
it?
Exactly.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.